Hello, and welcome to our fourth episode of Clits and Coffee. I'm Melanie Milstein. I'm a physical therapist that works with pelvic health and orthopedic conditions.
And I'm Zoe Paul McPherson, and same thing, physical therapist in pelvic floor and ortho.
So hope everyone's doing great. We're really happy that you could join us today. Our topic today is going to be going over a patient case with someone experiencing stress urinary incontinence. So Zoe's going to start off with a little history of someone that might be experiencing this, and we'll talk a little bit about what that is and what type of things that we can do to help.
Yeah, so a patient comes in because they have incontinence when they're laughing, when they're sneezing. They kind of feel like things might fall out when they're jumping, or if they take like a step off a curb that's a little bit lower down than they had anticipated, so kind of like a surprise impact. And they are just hoping to get back to the gym, so they haven't been able to really run or jump, or they haven't lifted weights for about the last 5 years because they thought that it was dangerous for their pelvic floor symptoms.
Okay, good. So yeah, I think one thing I want to mention before we get into some questions and what your treatment looks like for this patient is just a quick definition of stress urinary incontinence. So that would be the concept of involuntary loss of urine with changes in pressure within their system. So the common one that you hear of is the loss of urine with coughing, sneezing, laughing, but it can also happen with other higher impact things like running, jogging, jumping, where there's an increase in pressure and potentially the pelvic floor isn't reacting appropriately, and then there'll be a loss of a leaking or a loss of urine. Anything else you want to add to that?
No, I mean, for her, I guess, like, we knew with jumping, but we didn't know as much with running or with lifting weights. Like, that was just kind of assumed because she thought it was dangerous, so she hadn't done it, and because she was having leaking with other things and what's called stress incontinence, she assumed that would be the case with exercise.
So yeah, what did your initial exam look like, or what things did you definitely want to check out with this type of patient?
So because she came in really wanting to like get back to the gym, and initially it actually, like, through our history, that wasn't what she said, but when I asked her, like, is that something you want to do? She said, yes, I would love to. I thought I never could. Yeah. So that's what guided the first visit. Was I was like, okay, like, we could do a pelvic floor exam, but what if we just went into the gym and did some exercise and started out with things that you feel comfortable with and progress from there this session and use that as our exam?
Okay.
So and she was like, game. She was like, all right, let's do it. The other thing she noted, she was like, well, with that, I'd like to build more strength because I feel like my core is really weak.
And then during that initial session, or even like within those first couple of sessions, were you able to ever recreate the incontinence during the exam? So, like, have her cough, have her jump. Was there ever a situation where you were able to, like, have her do something and then she's like, oh yes, this would recreate it, or this did recreate it?
She got the sensation that it might happen when we got to jumping.
Okay.
But she was able to jump for a minute.
Okay, gotcha. And then, whole minute. So just like double leg hopping in place?
Yeah, without actually having incontinence or the feeling of things falling out.
Yeah.
She just had the sensation that it might happen, and then we did a couple things with breathing, and that sensation went away.
That's awesome. Well, and just like the fact that she just wasn't avoiding those activities with the assumption that it's going to cause symptoms. And I think that's always really powerful and fascinating, is, we create these things in our head that might not really be there. You can jump and you're able to control your bladder, but until you try that, you just don't know.
Yeah.
Yeah, that's amazing. And then, like, so with, she had it, and she also had it with the coughing situation as well. Was that every time, like, when she would actually have the stress incontinence, was it happening every time she coughed, every time she sneezed? Did it change at all, like, just based on timing or anything like that?
So it was worse with sneezing.
Okay.
And so not every time, but worse with sneezing, worse standing, and the worst was unexpected.
Okay, gotcha.
So those were like the big things. Like the unexpected element was the biggest thing in her incontinence.
Okay. So, and you mentioned that you maybe gave her some breathing tips or techniques. Was there anything specific, or was it more just like, you should breathe during this exercise?
So we did like more of the like pursed lip breathing during jumping, and that pretty much resolved any symptom that she had.
Okay.
So just thinking about like for the exhale.
Gotcha.
We didn't do quick exhales. We didn't do it on impact. We just, when she exhaled, we blew through a straw.
Okay. Yes. And yeah, and there's, with exhaling, we do have that connection to the pelvic floor and the core, and which is the way our body should operate. So rather than, potentially giving her like a contraction of the pelvic floor, you did something the way that her body is supposed to work and had no symptoms.
Yeah.
Yeah.
And she was like pretty shocked. Like we started the exam with like standing on one leg, which left leg she could not balance on.
Okay. All right.
For 1 second.
Yeah.
Right leg totally fine.
Okay.
And then we did some strength assessments that were more active. So we started with like a wall sit. We did some glute bridges, left side, for everything was really weak compared to the right. For side plank, same thing. She could do a plank, but not for a minute. So like we had some true weakness in her core and some balance deficits, which could potentially explain like stepping off the curb and not being able to like catch herself unexpectedly.
Right.
So that was interesting, but we started, pretty basic of things she felt comfortable doing, even though she hadn't done them in a long time. And then I asked her how she would feel about jumping in place. She asked me if it was safe. I said yes.
Yeah.
And so she went for it.
Okay.
So it was like very progressive and gradual. And the biggest things that stood out were actually like non-pelvic floor things.
Yeah, definitely some like orthopedic, muscle imbalances, potentially some weakness in the core, glute area. Yeah, that's really great. So what did your initial, is that the stuff that you sent home with her? So glute bridges, wall sets, things like that, or what was her initial home exercise program like?
So we started with glute bridges. We went to like single leg glute bridge. We did some jumping, so box jumps actually.
Okay.
Because she was fine with like the hops in place, but when it came to like that sudden movement and sudden impact, box jumps seemed more appropriate.
Okay.
So we started with box jumps, planks, and glute bridges, and a walk run program.
Oh, great.
So like 5 minutes, we had done 3 minutes of impact. So we did 5.5 minutes of walking and 30 seconds of running for 6 rounds, because she went on like a 30-minute walk every day.
Okay.
So we did that to start, and then progressively added time of running over the like next couple weeks till I saw her.
Okay, awesome. And then when she came back to see you, so she had started some of this stuff, did she have any episodes of the incontinence between your initial assessment and the next follow-up?
Yeah, she had one episode with like a sudden movement on a run, and once with laughing, I believe. Nothing with running, straightforward, just basic running. And other than that, like the frequency of those incidents was lower.
Okay, yeah, that's great. Good question here. So if the suddenness is something that she continuously reports, how would you address that with potentially a treatment technique or a tip, or like what would you do during your session to replicate potentially a sudden movement or an unexpected one that we need her to be able to control?
So we started with like some ball tosses where I had a ball and I had her moving laterally, and she would be moving one direction, but she didn't know where I was going to throw the ball and she'd have to catch it.
Love that.
And we started unweighted, because the heavier the ball, the more impact, the more sudden impact to an unexpected. I mean, she didn't know when I was going to throw it,
so true,
or which direction.
Right.
And then she had to catch it and throw it back.
Okay.
And I would be moving while she had to throw to me.
Okay.
So just to try and get like a little element of surprise.
Yeah.
And then running forwards where mid-run I would bounce the ball one direction and she'd have to go and try and catch it.
Okay. Yeah, that's a great idea. And that like dual task, unexpected dual task in still a controlled environment, so you're at least like, prepping your body's response in a controlled manner, but with the unexpectedness of you tossing the ball, her having to toss it back, you moving and her moving. That's also going to add another element. I think that's really, really great. And then, so how did everything progress?
So she got to about 3 minutes of running at a time with 2 minutes of walking.
Oh, yeah.
Started lifting weights. She was like deadlifting. She was doing all the things that she wanted to get back to. We were doing bounding box jumps. We were doing depth drops. And everything was going well, and she was just like excited to work out again. Core strength was improving. We retested all the numbers, right, to make sure that like we were actually getting better at everything that needed to improve. Balancing, brushing her teeth on one leg, like that was an easy add-in.
I actually wanted to follow back up with, I had 2 other thoughts. You mentioned that she's been dealing with this, for 5 or 6 years, and somebody told her that you can't run, you can't jump, you can't exercise. How do you think is a good way to maybe address some of, patients or people might have a provider tell them something like that, and then it sticks with them for so long, and then you're gonna say that's not correct. We can do all of those things. How do you think it helps to help a patient trust you as a different provider who's giving them powerful information, empowering stuff so that they can exercise, but them still being like, well, I don't know if I should do that? How do you help build that trust?
I think it really depends on the person. Like for her, I was like, do you think that makes sense? Like why? And if so, why? And she was like, I really don't think it makes sense.
Yeah.
And I was like, why is that? She was like, because like I've seen moms do these things, so that just can't be true. And I was like, well, how would you feel about us just going out and trying some things, and you let me know if you're nervous, and you're in charge of everything. Like you decide when you stop, you say no if you're not comfortable with it. I will propose ideas, but this is your session. Like, right. How do you feel about just trying it? She was like, okay. So that was like easy, I think, for her. Like she really, really wanted to do those things. So I think it was an easy sell to make it okay. But for someone who would be really nervous and who probably has more symptoms than her, I think it would be a slower process. I don't think I would have tried jumping that day.
True.
We probably would have done a modified plank to start. There's other things that I would have done, like ask her potentially like, okay, what are 3 exercises that you feel comfortable doing? And take note of those, do those, and then do a variation of them that's harder.
Okay.
But I think it depends on the person, where for her, like just with coughing and sneezing and laughing, like she said jumping, but she said she hadn't tried it in so long, and she was like so game for it that it's not hard to convince her.
Definitely. Yeah, I think that like gradual approach, and then just letting her try it, like seeing what happens when she tries it, was really important in her situation. And then, my final question or thought. So it seems like with her situation, maybe someone who has a lot of other orthopedic findings. So, you didn't really have to do a pelvic floor exam, and you really focused on these other things that stood out to you: her breathing, her, what does her balance look like? What does her plank look like? What is her glute strength like? What do those things look like? And then you made those adjustments there. For someone else with stress incontinence, how would it look different?
So I still did do a pelvic floor exam the next session.
Gotcha.
So I think for someone else, we may have, if their symptoms were a little more severe, we may have started with a pelvic floor exam.
Okay. Mm-hmm.
Depending on the person, because she came in and was game to move right away. Like, if we can get someone moving right away and confidence in that, like we can do pelvic floor exam next time. That's fine.
Yeah.
But for someone else, we might start with a pelvic floor exam because that's, for a lot of people, the biggest complaint. So let's see what's going on. They want to know.
Right.
And so doing an internal exam. And for her, because her symptoms were mostly in standing with coughing and sneezing, I did a standing pelvic floor exam.
Yeah.
So meaning like lying down on her back, I looked to see what happened when she coughed. Good pelvic floor contraction, no incontinence. We did the same thing standing because everything looked good lying down. I can't assume it looks the same standing, and it didn't.
Yeah.
So what happened standing was that there wasn't a pelvic floor contraction with cough. She had good strength. We tested that in standing. So teaching what's called the knack, where before a cough, you're doing a pelvic floor contraction. And we practiced that in standing because that's where she had symptoms.
Yes, very, very important. And yeah, the standing exam can provide completely different information, more valuable information, especially for a patient that's experiencing symptoms in standing.
Yeah.
Yeah, great.
So that's probably for anyone else, like it would have been the same route, but maybe we do that first.
Right.
Or like if it's at the bottom of a squat, like let's look what happens at the bottom of a squat.
Yes.
You know, the nice thing about physical therapy exams is that we can do them in the positions for the most part that you have symptoms. And so I'm not ever going to assume that what's happening lying down is happening standing.
Right. Yeah, and really tailor it to the patient in front of you as opposed to like having a set way that it always has to be this way. But a lot of times, the lying down supine position isn't going to be enough force from gravity, enough intra-abdominal pressure to create their symptoms. And that's what we really do need to see so we know how to best help them.
Yeah.
Any other thoughts for this one?
I mean, I think my big takeaway, it really was just giving people permission to exercise.
Yeah.
And that like trying something, especially with where you've read all these things online and you're nervous, like doing it once is not going to cause long-term damage.
100%.
And so it's okay to try.
Right.
And I think like it, as providers, it can be shocking to hear that. To me, the bigger message is that like that being out there and the knowledge that people have being so wrong, that's what's hard to deal with.
Yes.
Like the symptoms and pelvic floor stuff, like we can address, but this like held belief, for her it was so easy, but for other people it's not gonna be. And so just the more that we can share, like it's okay to try things.
Right.
And then ask for help if you have symptoms. Like, let's do that.
Right. And then my takeaway from this patient scenario would be your treatment and your exam did not have repeated Kegels, repeated pelvic floor contractions. That wasn't even mentioned except for doing the knack, which is a thing that does work. It was addressing the system the way that it's supposed to work, addressing body positions, addressing breathing, versus having someone do the contractions over and over and over again, and then they wind up coming to potentially see us and they're like, well, I've been doing pelvic floor contractions and that's not working. And it's like, well, because that's probably not what your system needs, because it's not the way that it works.
Yeah.
So yeah, I think that that's also a good takeaway from this patient scenario.
Yeah, absolutely. Actually, one of the more shocking things was, so there's a 5-point scale for muscle testing in PT. And for pelvic floor, I think I primarily see a 4 out of 5.
Yeah.
She was the only person I have ever done an exam on who, without a doubt, was a 5 out of 5.
Oh, right. So she doesn't need more of that. Yeah.
Like, I honestly, like, I've had some where I'm like, oh, that's a 5 out of 5. I was like, that is a 5.
That is the 5.
Based on this scale, that is a 5 out of 5
Yeah.
in lying down and standing 100%.
Yeah. Yeah.
So that was like interesting where I was like, not weak.
Right. That's not the issue here. It's that mismanagement of pressure that we need to address.
Yeah.
Yeah, that was really great. Good. All right,
next time.
Next time.
We're very excited because we are going to talk about pelvic floor exams from a PT perspective and an OB perspective because a friend of mine is an OBGYN and she said she would join us.
Yeah, so we're going to get to see both worlds and see how they're similar, but in probably a lot of ways they're going to be very different. So we're really excited for that and sharing that next time.
Yeah, and if you like this, like, share, follow, all of the things.
All right. Have a good day. Bye.